Great. Let's discuss the whole respiratory system, starting with the hyoid bone all the way downwards on this model and a couple of the other models that you will see here. And what we'll notice is right away, right, the hyoid bone is at the superior margins of this. And keep in mind that both the respiratory and the digestive system start out with openings at the mouth and the nose. So as we go down the pharynx, the throat, we're going to have a separation between the digestive posteriorly and the respiratory anteriorly, and this is the actual start of the pure the respiratory system that we see. So you have the hyoid bone here. Below that, you have the thyroid cartilage. The thyroid cartilage is going to actually fuse together in the middle, and the appearance of the fusion over there is going to give us, for the males, the more prominent Adam's apple. Right? Now, once you know the actual name of the cartilages, the muscles that connect the cartilages as well as the membranes that connect the cartilages are pretty easy. So here's your thyroid cartilage, here's your hyoid bone. This whole area right here, connecting those two regions, are called the thyrohyoid membrane. Immediately next to that, you'll see the thyrohyoid muscle, right, from the thyroid to the hyoid. Now, what else do we see here is a very important artery, the superior thyroid artery coming down and around onto the thyroid gland. As we look to the next region right here, you'll see a number 3, and that is our cricoid cartilage. The cricoid cartilage has what we call a signet ring appearance, meaning that it's very small on the side right here, right in the front. But when you look at the back right here, you'll notice that the actual cricoid cartilage is actually pretty big. And not only is it very big, it's got some very important structures that it's attached to, or that's attached to it. Right? So the first thing you'll notice back here is that you see a triangular type of cartilage called the arytenoid cartilage that sits right on top of the cricoid. Now, the arytenoids on one side is actually attached on one side, right, to the true vocal cords. Right? So movement of the arytenoids will cause movement of the true vocal cords. Now, the question is, what causes movement of the arytenoids? Usually, this cartilage sitting right on top of the arytenoids, called the corniculate cartilages right here, right, are going to be where we're going to have movement. The corniculates are sitting on top of the arytenoids. The movement of the corniculates are going to move the arytenoids, which are going to move, therefore, the vocal cords. Right? What else do we notice? Is that, right, again, like we mentioned, the muscles are going to be named based on where they're found. So you see this from the cricoid to the arytenoids. This is the cricoarytenoid cartilage muscle. And then from here to there, right, you have the transverse arytenoid muscle that kind of crosses over. This area right here, this is our epiglottis. Now, as we go further down, right here, we will notice then that you're going to see a really thick ligament that connects the cricoid to the thyroid. This is a median cricothyroid ligament, and the muscle immediate lateral to that is the cricothyroid muscle. As we go further down, the trachea is seen, and the trachea are C-shaped rings of cartilage that to the front looks like little plates of cartilage. When you look at the posterior view, you see a trachealis muscle right here. Right? The trachealis is a smooth muscle, and its main purpose is to allow food that's going down the esophagus to go down as a bolus, and when the bolus of food travels down the esophagus, it prevents the movement of the trachea forward. Instead, the food that's going down the esophagus will kind of push in on the trachealis, right? Therefore, the whole trachea doesn't move forward every time we swallow. When we look at the actual lung right here, you'll notice that the tip of the lung is pretty high up. The tip right here is called the apex. The apex, you'll see, is actually about 1 or 2 centimeters above the subclavian artery and vein. In reality, it's actually about 1 or 2 centimeters above your clavicle as well. So injuring the clavicle and breaking it internally can cause somewhat of a lung disorder. It can actually cause a pneumothorax if it's large enough. Now, on the right side, since there's no presence of the heart, there's more lung material. And we're going to see that there's 3 actual secondary bronchi on the right side, or 3 lobes on the right side. We're going to see superior lobe, and then you're going to see what's called the horizontal fissure separating the superior from the middle lobe. The middle lobe then is separated from the inferior lobe by the oblique fissure. And again, right side, no heart, therefore you're going to have more space for lung matter. On the left side, we only have 2 lobes, right? So the 2 lobes are the superior lobe above this oblique fissure, and below the oblique fissure is your inferior lobe, with the diaphragm over here separating the thoracic cavity from the abdominal cavity. Now, the presence of the heart also allows us to have this notch right here. This is called the cardiac notch, which then goes forward a little bit, turning into the lingula. Keep in mind that the left side of the thorax is going to be very, very crowded. So you're going to have less lung matter. And when you look at the actual bronchotracheal tree right here, you'll notice that, right, you're going to have on the right 3 secondary bronchi. On the left, you got the primary bronchus, and then only 2 secondary, corresponding with the 2 lobes on the left and 3 lobes on the right. Now, one other thing that we need to kind of keep in mind is that because of the presence of the heart, the left primary bronchus actually is going to, bifurcate first, right? So it actually bifurcates a little bit above the right.